This is Susan Boyer, and I'm going to be discussing our chapter on magnetoencephalography, MEG, also known as magnetic source imaging, MSI, by Anto Bagic and Susan Boyer. The objectives of this chapter are to understand how MEG and MSI have the ability to non-invasively localize abnormal epileptic activity with a spatial resolution of less than 5 millimeters. Also, how they can localize eloquent cortex, especially in patients without structural abnormalities. MEG and MSI can identify displaced anatomical landmarks. It can also assist in optimizing the surgical trajectory for an intraoperative navigation and operation. This figure outlines the principles of magnetic source imaging. With respect to the orientation of the neurons, these cerebral sources can be divided into two types, tangential and radial. The tangential can be seen on the MRI image in panel A as the blue areas mostly on the banks of the fissures or basal planes of the lobes. The radial sources, which are red, mostly seen on the crests of the gyri. In panel B and C, they show the magnetic field pattern, and that can be seen as the dashed circle lines circling the thick fibers. In panels B and C, the orientation of the current flow matters because it reflects the orientation of the current vectors that produce orthogonal magnetic fields according to the right-hand rule. Specifically, if you extend your thumb in the direction of the prevailing current flow, and curved fingers will point in the direction of the corresponding magnetic fields. The boxes B and C, they have an arrow representing the current flow, which actually contains tens of thousands of parallel and simultaneously firing pyramidal cells. The dashed circular lines surrounding those thick arrows in the red and the blue are the orientation of the magnetic field. Therefore, in the case of the radial source in box B, the red lines are the magnetic field, and you will see that they do not exit the skull and impinge onto the magnetic sensors. While in box C below it, the blue tangential sources, you can see that the magnetic field, the dashed blue lines, actually reflect outside of the skull and impinge on the magnetic sensors and are therefore recorded better than the radial sources. In Figure 2, Panel A is a currently available MEG system positioned for recording in the seated position. Panels B and C are actual MEG tracings. C displays the entire head panel with the circle enclosing waveforms that have multiple spikes in the right temporal region. These are better seen in panel B, where the red arrows indicate the spikes. In panel D, the morphology of the spike can be more fully seen. In panel E, the corresponding magnetic field patterns are seen as red exiting the head and blue entering the head. Therefore, putting your fingers in the direction of coming out of the head and then going into it where the blue is, you'll see that your thumb will extend in the direction of that green arrow showing the direction of the underlying current flow. Panels F, G, and H display the final MSI result of the source location of the spike overlaid on the patient's MRI. This figure illustrates several MEG utilization scenarios. Each of these images is from a different patient. In panel A, the green dipoles are all clustered, indicating a well-lateralized left interhemispheric focus. In panel B, you can see the dipoles in green are all on the insular area, and this is a patient that has insular epilepsy. In panel C, the dipoles cluster showing the posterior intersylvian focus. In D, the dipoles seen in green are around the large area of the encephalomalacia. In panel E, the dipoles are all inferior to a previous resection. And in F, note that the MEG dipoles, as shown in green, are clustered around the epileptogenic tubers, and this is a tubular sclerosis patient. This figure is a case study from a non-lesional extratemporal epilepsy patient. This is a 29-year-old male presenting with a history of falls in childhood, headaches, hypertension, depression, and epileptic seizures since the age of 5 years old. He has failed 2 anti-epileptic meds and continues to experience seizures on his current anti-epileptic medication. In his pre-surgical evaluation, he underwent both a 1.5 Tesla and a 3 Tesla MRI, a routine EEG, a video EEG, neuropsychological testing, an FDG PET, and MEG with EEG at the same time. In panel A, this indicates that no structural abnormalities were seen on the 3T MRI. In panel B, you can see a normal FDG PET. In panel D, there's positive findings from an MSI study, which indicates significant cerebral dysfunction and epileptic activity seen in the right inferior parietal lobe. In panels C and D, a 3 Tesla MRI spectroscopy was performed, indicating a significant metabolic abnormality in the right inferior parietal lobe. The yellow lines seen on the scout images in panels C and E outline the estimated position of the central sulcus. This is a case study from a drug-resistant epilepsy patient who had seizures, which began as a young child. They were characterized as type A, where there was right hand jerking but maintained awareness, as well as an inability to respond, and type B, where he had an increased heart rate, which was followed by dialeptic seizure. He had no epilepsy risk factors and a normal MRI. His first video EEG evaluation at age 9 captured unclear events that appeared to implicate the right frontal region, and a second video EEG evaluation recorded 10 seizures from the right central region. At age 10, another video EEG was performed and found left temporal sharp waves, while seizures were recorded from both the left temporal and the right parietal central regions, prompting a MEG study. The MEG study can be seen in the upper left-hand panels and identify interictal discharges that were mainly seen in the MEG, not in the simultaneously recorded EEG. These dipoles are all in the left anterior temporal lobe on the left superior temporal sulcus. The PET scan, which is in the upper right, shows the left anterior temporal hypometabolism. The arrow there is pointing to that area. Below that PET image are 2 conflicting results which were found from the 2 SPECT scans. The first is the bioccipital ones, where the red regions can be seen greater in the right than the left brain. And the second, which is showing that there is more left lateral temporal areas active. Because of the non-concordant data and concern about left temporal language, the patient had an invasive evaluation with a stereo EEG at age 15. These can be shown in the bottom panels on the right-hand side. They show that the seizures were arising from the left hippocampus and the lateral temporal region, as seen as the red dots on the images down there. The green lines are the location of the stereo EEG probes. He underwent a left anterior temporal lobectomy, seen as the yellow area in that lower right-hand panel. After an initial preoperative seizure, he was seizure-free for 2 years. Unfortunately, the seizures then recurred and were similar to those before the first surgery, but far more frequent. A second postoperative MEG was performed. These can be seen in the lower panel on the left-hand side, and this demonstrated that there's still abundant, consistent interictal discharges, now entirely without an EEG correlate, in exactly the same region as the first, in that left superior temporal gyrus, just above the resection cavity. This figure shows a patient pre and post tumor removal. This displays the 3D integration of brain anatomy and function to facilitate the intraoperative navigation around the sensory motor strip. In panel A is a 3D surface rendering of the brain of a patient with a tumor that's easily seen in the sensory motor region. The dots indicate the equivalent current dipole locations for responses to the median nerve in blue, the tibia nerve in red, the lip in yellow. The auditory evoked fields are in white, and the MEG, EMG to the right wrist is green, and the MEG, EMG to the ankle extensions are in blue, and these are displayed on the surface. In panel A to the right are the sources of the SCFs to the median nerve and the lip stimulations displayed on two horizontal MRI sections. Note the distortion of the functional cortical anatomy by the slowly growing tumor. In the middle panel B, on the left-hand side, the 3D surface rendering of the patient's brain, including cortical veins and the sources of the SEFs and the AEFs. The top to the right is an enlarged section of the 3D MRI surface rendering. The bottom corresponds to the brain surface during surgery. The veins are readily identifiable and allow the localization of both the sensory cortex and the tumor area. In panel C, on the left side, you have the postoperative surface rendering of the patient's brain, sources of the MEG, EMG coherence for the right wrist and the ankle extensions, and the median nerve and the tibia nerve SEF and the lip SEFs, and the auditory evoked fields are all displayed on the surface. The right side of that, the sagittal and coronal sections of the postoperative MRIs with the sources of the median nerve and the hand MEG coherence displayed. This is an example of a language localization and lateralization by MEG mapped with multi-resolution focal underdetermined system solution, MR focus, known as a current distribution technique. In panel A, activity in Wernicke's area was detected in the left superior temporal gyrus at 239 milliseconds after picture onset during a picture naming task. Directly to the right, you can see the latency where the peak is at that was used to detect this activity. In panel B below it, activity in Broca's area was detected in the left inferior frontal gyrus at 336 milliseconds after picture onset. In panel C to the right, the laterality was negative, meaning that it was below the 0 line, indicating that the left hemisphere was more active. The yellow arrows in A and B correlate with the red circles seen localizing around Wernicke's latency and Broca's latency. The laterality index was from 0.15 to 0.8 seconds. The amplitude was 20% greater on the left hemisphere, and activity was seen as 39% more of the time in the left hemisphere, indicating that this patient was left language dominant. This figure is a MEG-based algorithm for pre-surgical determination of the lateralization of language functions. If language lateralization is necessary, but memory lateralization is not, then MEG could give you a conclusive result and you could go straight on to your resection or your intracranial monitoring, ICM. If MEG is not conclusive, then you could go for an fMRI. If your fMRI is conclusive for language lateralization, you could go straight to resection or ICM. If the fMRI is not conclusive, or if you need memory lateralization, then a WADA would be required. If there's suspected overlap of language cortex with the epileptogenic zone, or finer verification of the eloquent cortex location is required, then you would need to go on to cortical stimulation mapping extraoperatively or intraoperatively before you could go to your resection or your ICM. This is an example of a patient where we've looked at multimodal MSI integration for his medically resistant epilepsy. You can see in panel A the MRI, in panel B is the PET results, C is the SPECT results, D is the MSI results, E is the MSI and the PET overlaid, and F is the MSI and the SPECT overlaid. This is a 21-year-old right-handed male who had started to experience seizures at age 9 that often began with a tickle in the back of his throat and laughing or giggling. He experiences focal seizures with alteration of awareness, focal evolving to bilateral convulsive seizures, and recurrent status epilepticus in spite of multiple anti-epileptic drugs. These seizures are of unknown etiology in spite of extensive evaluation. It was only recently that his left hypothalamic hematoma was identified, as seen by the yellow arrow in MRI panel A. After a detailed multidisciplinary consideration of his evaluation, it was recommended that he undergo radiosurgery, which led to no improvement of his frequent seizures. MEG, 3T MRI, and indirect functional methods, PET, SPECT, were completely congruent in revealing a very active left anterior temporal irritative and ictal zone. Because evidence suggests that removal of brain regions containing MEG clusters leads to a favorable surgical outcome, and the patient has already failed radiosurgery, it remains to be seen if this patient will need an operation in order to attain seizure freedom. Here we have included a comprehensive algorithm for the pre-surgical evaluation of patients with drug-resistant epilepsy. If you have a clinically significant lesion on the MRI, concordant electroclinical data, acceptable risk-benefit ratio, you could go on to resective surgery. If not, the patient usually undergoes what's universally accepted as a phase 1 evaluation detailed here in the top. These include non-invasive investigations. Then there's challenges or ambiguities. These are most commonly listed here in the purple ellipse that ensue, and these may be resolved by obtaining a MEG for the purpose of identifying and localizing the seizure focus or foci. Specifically in the case of normal, also known as non-lesional MRI, when electroclinical and imaging data are discordant, if dual pathology is suspected or confirmed, in such situations as when a lesion or lesions are adjacent to the eloquent cortices or multiple lesions are present. Considering the effect of a previous surgery can have on a scalp EEG, many experienced magnetoencephalographers believe that every epilepsy patient undergoes a diagnostic therapeutic resection should undergo a MEG, since it is unaffected by any skull defects from a previous surgery. Here we list the most common evidence-supported indications for MEG in drug-resistant epilepsy, along with the supporting literature. First, lacking or imprecise hypothesis regarding a seizure onset. 2, negative MRI with a mesial temporal onset suspected. 3, multiple lesions seen on an MRI. A large lesion on an MRI. Diagnostic or therapeutic reoperation. 6, ambiguous EEG findings suggestive of bilateral or generalized pattern. Intrasylvian onset is suspected. Interhemispheric onset is suspected. Insular onset is suspected. And finally, negative, meaning that there's no spikes on the EEG. MEG has been successful in detecting epileptic activity.